Hello everyone, my name is Georgina Morris and I'm a final year medical student at the University of Manchester. I'm feeling very happy and very privileged to have been given this opportunity to present my poster on behalf of myself and my team at the Christie NHS Foundation Trust. And this is a retrospective identification of patients with intrahepatic cholangiocarcinoma initially diagnosed with a carcinoma of unknown primary. So to start off with, what is a carcinoma or cancer of unknown primary? Otherwise referred to as a cup, this is essentially where a cancer has spread to other organs such as the liver or the lymph nodes sometimes, but it's actually difficult to establish where that cancer actually started in the body. This is quite rare and accounts for roughly 1 in 50 of all cancer diagnoses. And in recent years, research has had a focus on trying to identify where a cancer of unknown primary started by looking at blood and tissue markers. Studies to date have shown that as many as 1 in 5 patients with a cup have markers that suggest that their tumour may have originated from the biliary tract. And this poses the possibility of misdiagnosis of these patients, and therefore they may actually be not receiving appropriate treatment. As some of you may already know, cholangiocarcinomas are the second most common liver tumour, and they arise from the biliary tree. There are 3 types, which I've highlighted in this figure here, and cholangiocarcinoma, the intrahepatic type, or iCCA, is the most common of these. Many of our patients will present with quite advanced disease, and this just highlights the importance of further investigation into new treatment options and management strategies for this group of patients. In terms of the diagnosis, this can be done involving a number of different strategies such as ultrasound, CT imaging, which I'll come on to shortly, and MRI imaging, as in MRI scans. However, also blood and tissue markers have become a focus of research, as I described in recent years. Due to the advanced presentation in some instances, curative surgery isn't always possible, so many patients are offered the gold standard treatment, which is cisplatin and gemcitabine chemotherapy. However, an area of more importance recently in research has been that of genomic testing, which has allowed the identification of certain changes such as isocitrate dehydrogenase or IDH mutations and fibroblast growth factor receptor or FGFR fusions. With this, new targeted therapies have been developed, such as the FDA-approved pemigatinib, which is now being used for second-line treatment in these patients with iCCA who have these molecular changes. In terms of our study, we identified a group of patients, 233 patients, who had cancer of unknown primary from our databases at the Christie. We then aimed to establish how many of these patients had a potential diagnosis of iCCA. We did this in relation to our entire patient group, so the 233 patients, and also looked specifically at patients with liver involvement after excluding those patients who didn't have liver disease. The reason we chose to do this is that by definition, patients without liver disease could not have a cholangiocarcinoma, as this is a primary liver tumour. Our study period was established as being between January 2017 and April 2020. And for this period, we collected information on the demographics, performance status, and multidisciplinary team discussions for each patient. So we were actually able to identify that there were 74 of our patients who had some form of liver involvement, and they then went on to have their radiology reviewed by a specialist oncologist and an oncologist and a specialist radiologist at the trust. And these images were then classified according to the table at the bottom of the slide. The images on the right-hand side of this slide are in fact CT scans that have been taken from 2 set patients, with the patients lying flat within the scanner. The reason I've included these is to demonstrate the features that we looked out for when identifying what could be considered an iCCA and what would not be considered an iCCA. For example, on the image on the left-hand side, we can actually delineate the liver, and at the top of the liver, there is an area of darker, there's a darker area. And this is what we would call a dominant lesion in the liver, and this is in keeping with an intrahepatic cholangiocarcinoma. In contrast, on the other side, we can also delineate the liver, but though it may be a little less obvious, there are these smaller, discrete dark lesions that are scattered throughout the liver. And this is more in keeping with a cancer that has actually spread from elsewhere in the body to the liver. And this is what we would call a non-iCCA. Patients whose imaging didn't quite meet either criteria were then identified as a possible iCCA, and those who didn't have a scan available were established to be non-evaluable. Our patients who had iCCA and possible iCCA were then pooled together for a more detailed analysis of their pathology and their genomic testing. Just to summarize, our entire patient population consisted of 233 patients. 74 of these patients had liver-inclusive disease, and we identified 26 patients who were found to have iCCA. When looking at the comparative demographics of our patients, patients with iCCA tended to be on average younger, so 65 compared with 70. There were more female patients, so more than 3/4 of the patients compared to 50%. And fewer of our patients with iCCA had a good performance status. Now, performance status is essentially an indicator of how fit someone is. And this to us suggested that in general, our patients with iCCA were less fit. When looking at our key findings, we were able to conclude that iCCA accounted for 11% of all of our cancer of unknown primary patients and 35% of those with liver-inclusive disease. In terms of our MDTs, patients with iCCA were discussed on average at one multidisciplinary team meeting, and the figure on the top right demonstrates that 9 of our patients were actually discussed at a hepatobiliary MDT meeting. The image on the bottom left and the bottom right is actually that of a summary of the treatments that our 26 patients received. This showed that 50% of our patients received chemotherapy, and of these, 1 patient received the gold standard treatment for iCCA, and 54% received carboplatin and paclitaxel. When looking at the genomic testing, 2 of our 26 patients were found to have enrolled in trials where their tissue was available for molecular profiling. 1 of these patients was found to have an IDH1 mutation and 1 an FGFR fusion, both of which are commonly seen in iCCA. Some of the important take-home messages I'd like to highlight before I complete my presentation is that of iCCA accounting for roughly 1 in 9 of all of our cancer of unknown primary patients, and around 1 in 3 of our patients with liver-inclusive disease. 65% of our patients with iCCA actually have no record of having been reviewed at a hepatobiliary MDT. And this suggests that opportunities to discuss novel treatments or alternative management strategies in a specialized setting were actually missed. Those with iCCA were generally younger and more often female. And one of our consultants at the Christie on our CUP team actually has gynae oncology experience as well, which may explain the increased use of a carboplatin and paclitaxel therapy, which is more commonly seen as an ovarian regimen. Nearly 2/3 of our iCCA group had a performance status that meant they may have actually been eligible for a treatment with cisplatin and gemcitabine. And another key point to raise here is that even in the context of a cancer of unknown primary that is suspected to be an iCCA but not yet proven, this sort of regimen can actually be used in place of other therapies. And finally, we had 2 patients who had mutational analysis performed, and both of these patients demonstrated changes that are commonly seen in iCCA. And this just highlights the absolute importance of this analysis, especially in the context of these new targeted therapies that are being developed. We would like to propose an alteration to the current CUP pathway with the introduction of an iCCA specific subgroup. This, we hope, will provide guidance in terms of the radiological features to look out for in the context of analysing images in CUP MDTs, as well as encouraging the use of genomic testing as a standard of practice going forward for identification of these new therapeutic targets. This, we also hope, will allow for a better appreciation of the true epidemiology of iCCA in terms of how common it is in our population, as well as making the care and treatment of this group of patients the best that it can be going forward into the future. Thank you very much.